wish you all a very warm good evening from the UK. I'd really like to thank the organizers for inviting me for this lecture. It is truly an honor and an absolute pleasure to join all of you here. So today we'll be discussing this topic of biomarkers in myositis, while we wonder and discuss if we are there yet. So when I was allotted this very difficult and seemingly boring topic, I wondered what all we could discuss. And I thought maybe we could gently walk through the definition and understanding of what a biomarker is first. So first things first, putting things in perspective, a biomarker is any objectively measurable characteristic whose alterations can be used to recognize and monitor a normal or pathologic process. And technically, this could either be a physical sign, a cellular or genetic marker, a protein, or even an imaging tool. And for simplicity's sake, biomarkers could either be those that we could base our actions on, or maybe those signifying underlying mechanisms of disease process. These could also be single or a conglomeration of many different biomarkers, which could be either homogeneous or disparate entities. And the prerequisite of a good biomarker is that it is non-invasive, cost-effective, easy to measure, repeatable, and precise. So why do we need biomarkers at all, if you were to ask? So the future of medicine, we all know, is precision medicine, and the whole objective is to tailor therapy to individual patients rather than tailor an individual to standard guidelines. And what do we really need from a biomarker? They could either be useful for diagnosis or for prognosis or even follow-up and treatment monitoring. Now, if we were to look at myositis antibodies, the most important component used in diagnosis of myositis, they could technically be the Watson 2 Holmes and help with early diagnosis, serve as a very good biomarker at times, even to understand the direction of progression of an individual in terms of organ involvement, which could also in turn determine the choice of immunosuppressant. For example, recently this image was doing the rounds on Twitter and it became hugely popular over a matter of few days. And as we see, this patient had palmar papules, and oftentimes we see such individuals presenting in the critical care setting, sometimes in a background of acute interstitial pneumonitis, where other clinicians may not have a single clue. And in such a scenario, antibodies like MGF5 could be life-saving by establishing the diagnosis. Now, good to know that anti-MGF5 positive patients can have mild presentations. For example, in Japan and China, where they're way more common, they could present as an acute interstitial pneumonitis, while in Caucasians, they could be very mild, presenting just with arthritis and mallar rash. While in other areas like the United States and India, we could have a biphenotypic presentation. So with the added advantage of having so many different tests to our disposal, we also encounter what I call as accidental biomarkers in the clinic. And oftentimes you'd be wondering, why was the test ordered at all, and how do I now conclude something? So for example, a patient comes with rheumatoid arthritis, well-established diagnosis, erosive arthritis, long-standing disease, maybe 2 or 3 years, not long-standing, and a positive anti-EJ test. For God's sake, why was it even ordered? Now, what do I do as a rheumatologist? This is something which you would have encountered often in these times, and this is one of my favorite slides. Some of you might have even come across this earlier. So with time, we're understanding that the anti-synthetase antibodies may actually precede clinical illness by several years, and there's this emerging concept of pre-antisynthetase syndrome. Now, incomplete forms of ASSD, whether with anti-EJ or any other antibody, are more common, and these are increasingly evident with the wider testing. Now, the interesting bit is many of these patients over a 12 to 24 months follow-up period tend to evolve to complete forms of ASSD, and the disease may not necessarily begin in the muscle. And to make matters worse, arthritis can often be erosive, and RF and anti-CCP may even be positive. In some series, they've shown up to 1/3 of individuals. So that's an example of a good biomarker, maybe because it's important. As non-joven disease, like the one we just saw, anti-EJ, they may be diagnosed late, and it is very well known that there's a median delay in diagnosis in those who do not present with myositis. And the cause of death is undoubtedly due to underlying disease that went untreated, like pulmonary artery hypertension or interstitial lung disease, and many of them go on to have lung transplants. Another good biomarker, which is easily available and often ordered, but not reported satisfactorily, is cytoplasmic ANA, which can be an excellent screen for underlying myositis. And always ask for this in immune fluorescence assay when suspecting myositis. There can be other clinical markers that may be specific to certain populations, as was seen in our Indian cohort, where anti-MDA5 positive disease, edema of the eyelids could be suggestive of an underlying MDA positive disease. Now, this is a massive topic, and in the interest of time, we just touch upon a few other notable clinical biomarkers. From the last year, a few papers published suggest edematous myositis. So those presenting with subcutaneous edema, it may be an early sign of dermatomyositis. And not just that, nearly 80% of these individuals might have either cancer or a high mortality risk within the first year after diagnosis. Another important biomarker could be anti-Hmgcr antibodies. And this paper has shown that some individuals who are young and have a slow and grumbling disease with the wrong level of LGMD were in turn positive for these antibodies and could signify IVIG responsive disease. Now, considering that antibodies are not sine qua non for diagnosis, and there is a need of improvement, a felt need for sure. The antibody assays can sometimes be false positive and also false negative. So we need the gold standard, that is immunoprecipitation assay. And even with IP, there can be conformational epitopes specific to different ethnicities. So maybe with the detection of newer antibodies in specific ethnic groups may be the way forward. Further, wider availability of anti-Hmgcr antibodies, which are not very well available in India at the moment, or better assays that can help with high throughput. Now, always important to put things in the right clinical context, as false positives are known to occur even with the myositis-specific antibodies, especially with the line immunoassay. Some antibodies like anti-TIF and anti-MI2 may be false positive more often. So always keep an open mind and eye out with suspicion. That was about diagnosis. Talking about disease activity, the other major concern in patients with myositis, so muscle enzymes are used by convention, but not all of us know that creatinine kinase can vary greatly by ethnicity, because it's predominantly that muscle mass that determines the levels of CK. And it is very well shown that the levels can be the highest in African men, and India data, unfortunately, is lacking. However, in our setting, we've observed that SGOT may be particularly useful, especially when other causes of a raised SGOT like hemolysis or liver disease are ruled out, because aldolase is not always available. And this is data from the myocyte cohort, where we found that AST had the highest area under the curve for predicting active disease, while CK could be normal in up to 20% of our population. So we've explored other markers as well, just like many other researchers wondered if it's not just muscle enzyme, but something that has intersection with the metabolic function in the muscles could help. And therefore we looked at this marker and did find that it was higher in active disease, and better so in early disease. suggesting that maybe there's a cleaner separation because of the effect of fibrosis confounding the picture, as is seen with many other markers reported worldwide. But we did find that AST performs the best, and it is a simple and reliable test. Now, would you be happy with that kind of an area under curve? I probably would not. And the reason being that activity in myositis may not always be the muscle, and also can be confounded by loss of muscle during active disease, which decreases the possibility of getting a high biomarker, and also replacement fibrosis. So considering all these problems, we looked at something which was more aligned with the pathogenic process in the muscle, and looked at Metabolomix, which is many different metabolites, all small molecules, 1 to 5 kilodalton inside put together. And we did find that they could differentiate active from inactive myositis, as we can see here, although there was a significant overlap. Still, some of the metabolites did seem to be more significant than others. These are a few of them listed, and if we go through them carefully, they do tell a story. So there were underlying patterns like anaerobic metabolism was seen in active myositis, like low glucose and increased lactate, also increased muscle catabolism as evidenced by increase in branched chain amino acids. We also found lower creatinine in active disease, which could be a surrogate for decreased muscle mass when inflamed, and increased phenylalanine to tyrosine and some other amino acids, which suggested an oxidative defect, as is expected in anaerobic metabolism. So the unique advantage of Metabolomix, we felt, was that it's the final common pathway and pathophysiologically more probable and plausible. And interestingly, no difference between the subsets of myositis. So this is something most other biomarkers struggle with maybe Metabolomix and interferon being the only two that survive the test. Now, we would like to know if the serum levels were actually a reflection of what happened inside the muscle. We did find a very clean separation between healthy controls and myositis group in the muscle. And these were largely attributed to difference in amino acids, suggesting that muscle loss may actually be a very early sign and seen in the muscle much before. Now, understanding the mechanism of muscle weakness in myositis, it is not always inflammation, and maybe that is why we're not there when it comes to biomarkers yet. And this is very well shown in mice models that inflammation comes on at 5.5 months, while way before there is decrease in the AMP dehydrogenase 1 levels, which suggests a deregulated metabolism in these individuals. So non-immune and metabolic changes may possibly be contributing to muscle weakness. And maybe at the future is in vivo muscle imaging and triangulation with serum and the muscle to actually see what's going on and which metabolites are the most reliable. Now, my prediction would be an amalgamation of various biomarkers that look not only at inflammation, but also fibrosis and metabolism. Other more and upcoming biomarkers, including the interferon signature metric, which is really popular these days with researchers and showing good results in the blood, as well as muscle and cutaneous biopsies. And also there is commendable work on NK cells in bowel fluid for antisynthetase syndrome and inflammation in the lung. Now, there's lots happening on the imaging front as well, with MRI-based studies suggesting utility, but larger IMAX initiatives are in process. And with ultrasound, there are excellent studies to suggest the diagnosis, particularly when you can see the fasciculations in real time in these patients who are not myositis, but possibly a dystrophy. But expertise is needed and results can't be generalized always. They may be center specific. Now, PET scan is one of those that might appear promising. And Martin et al. Recently suggested a cutoff of 1.73 for the SVV in the proximal versus other muscles. This is the longest thoracis, which uses the standard and identified this as a reliable marker, something that needs to be verified in further studies. Another promising biomarker, although in a small subset of patients, suggested that floor beta per PET scan can identify amyloid reliably in patients with IBM. And these correlated with more severe disease, more muscle inflammation, and high fatty infiltration. It can also be useful for diagnosis, particularly where we need to differentiate it from polymyositis, and something that needs to be looked at. Now, biomarkers can also be used for damage. Now, calcinosis, for example, is something we've struggled with for generations, and seems like we're finally coming to an understanding of the condition, really, as we will see in a minute. And we also looked at biomarkers for infections, other complications like bone health, predictors for mortality, and even other things that might not have been thought of. So recently, this path-breaking paper found that neutrophils are very important for accentuating inflammation and calcinosis, and they might possibly be the missing link that we were looking for so far between autoimmunity and damage in this refractory condition. And patients with calcinosis have higher neutrophil extracellular traps, and as we can see, cytokines can be the driver of inflammation in these, with IL-18 being significantly higher in these children. And dyslipidemia is the new kid on the block, although the correlations are at best modest, but there seems to be an underlying relation which could explain deregulated lipid metabolism, even in children with JDM. Other notables include prevalent vertebral fractures like bone health, so simple biomarkers, simple markers like decreased vertebral height on X-rays could incur a very high risk of fractures in future patients. Like those who had a prior VF, we saw that they had a 5 times higher risk of fracture, irrespective of disease activity and steroids. Again, other markers of poor bone health could include higher age and low radial BMD. We've looked at biomarkers predicting infection, something which assumes high relevance in the Indian setting, as we see a lot of them. And we found that low serum albumin at disease onset and a daily steroid of more than 6.25 may be important pointers, and maybe the only ones for high infection risk in these individuals. Other most important and hardest outcome is probably mortality. And we found that in the Indian population, anti-MDR5 has very high odds of adverse outcomes, and low BMI and absent rash are other factors which suggest worse outcomes, while the presence of arthritis, rash, and positive ANA may be protective. And a model inclusive of all the above parameters had a wonderful area under curve of 86% to reliably predict mortality. Another special mention is that of anti-MDA5 positive disease that can have very unique manifestations in Indian patients. And in this lovely collaboration with colleagues from JIPMER, we found that ulcerative Gaucherans and anti-Rho52 were significantly associated with mortality, something very simple to look at and always should be watched out for. Now, coming to a close, it may be time to even think of what was unthought of. We looked at kidney injury in myositis as something that makes sense with all the muscle enzymes pouring into renal tubules and may possibly be contributing to renal injury. And we did find that there were increased urinary biomarkers that were exceeding known population cutoffs for AKI. So something to watch out for, and we'd wait to see more studies. If you want more, watch out the oral presentation by the student. Now, you'd be wondering why no one's talking about the elephant in the room, that is COVID-19. Maybe we have an entire different session to this, but yes, we've found certain markers even predicting severe COVID and worse outcomes. And for more, maybe check out this oral presentation by the student. So to conclude, the perils of biomarker research are very many, including it being a heterogeneous disease, varied pathogenesis, wider and varied organ involvement, and then adding to that the complexity of ethnic variability. And also there are problems inherent to biomarkers. The exclusions galore, like they can get affected by renal disease, they can be not specific to a particular organ like the muscle, they may be arising out of cardiac muscle or other sources. So it sure is going to be a bumpy ride finding good biomarkers for this disease, but hopefully we would get there at some point. And because this is such a rare and heterogeneous disease, collaboration is the key. And together everyone achieves more. So maybe you should start collecting your myositis today and contribute to some of these wonderful global collaborative associations. Myself, as part of the myosite cohort, feel very proud to have contributed to some of these global initiatives. So in the interest of time, for the most updated review, suggested reading for some of you. Thank you very much. And for further questions, happy to take them on Twitter or email.